Welcome to our Ealthy webinar for today. My name's Bethan, and I will be introducing, and then I'll be handing over to our presenters today. Just a little note on Zoom. So during the session, if you have any questions, comments or thoughts, please feel free to put them into the chat. Virginia and Emma may not see them during the session, but they'll be there after if they would like to look at them. And then at the end, we'll have some time for questions and answers. So if you do have any questions and answers, please put them into the Q&A button that you'll see on Zoom, and then we'll have some time towards the end for any questions and answers. Today's session is being recorded, so you'll receive the temporary link at the end of the session, probably tomorrow, and then the recording will go onto the Ealthy website in the members area to look at your leisure. All right, so today we have Emma Smith and Virginia Allen, who will be talking together about communication. So Emma is a practice support mentor lead and a dietitian by background, and Virginia Allen, many of you who you should know or probably know, Virginia is a medical English writer, as well as a nurse, and also an active member of the Ealthy team. And today they're going to be talking about the role of dietitians in learning disabilities and in the context of communication. So over to you, Emma and Virginia.
Right. Well, I'll go first. I'm really looking forward to this, and I know you all will enjoy this because if you're like me, you don't know very much about dietetics. And I've had a couple of chats with Emma, and it's been really illuminating. But I'm sure you'll enjoy this. So let's get straight into it. So Emma, until recently, you worked in a range of acute and community settings throughout Hertfordshire, and you're specialising in adult learning disabilities. Can you tell me, or can you tell us a bit more about what your work involved?
Absolutely. So I wonder if to tell a story, to start from the beginning. So before studying to be a dietitian, I worked as a support worker, a personal assistant for children and adults who have diagnosed profound and multiple learning disabilities. And it gave me a really good insight into the highs and lows of daily living for those people. I supported their families and the community of people around them, and got to view what the world is like through their lens, how they take enjoyment from experiences that would be considered a small thing to a lot of other people. Things like the feel of running water, how jumping feels within your body, the sound of music, or seeing a train go past. I also got to see some of the challenges that someone who has a learning disability can experience, including health inequalities, things like accessing healthcare, accessing the right care services to meet their needs as an individual. That kind of led on to my career as a dietitian. So when people say to me, "Oh, why are you a dietitian?" I love food. I love eating. I love cooking. And so that's what led me down that path. But I'd got that learning disability background. So I then studied to be a dietitian. That was a 3-year course. My first job was working in a variety of settings. So it was in the community, running clinics, going to home visits. So that'd be people in their own home, as well as nursing homes, care homes, delivering patient education sessions. The dietary needs that the patients had would be a wide variety of different things, so including overweight, underweight, type 2 diabetes, allergies and intolerances, hyperlipidemia, IBS, irritable bowel disease, lots of different things. Alongside that, I also worked at an acute hospital. So I covered wards including care of the elderly, stroke, surgical, cardiology, orthopedic, so a wide variety. And that's typical as a band 5 dietitian. You get to sample a lot of different areas to then allow you to specialize if you weren't sure what you wanted to go into. But as mentioned, I'd already kind of decided where my path was going to go. So found an opportunity within that learning disability trust in the local area.
Mm-hmm.
As a learning disability dietitian, I'd get my referrals from speech and language therapists. So that's another one of the allied health professionals. They would do a swallowing assessment, and if someone had a diagnosis of dysphagia and had a dietary need, they would then get referred on to me. I would visit people in a variety of different settings. So that might be their own home, it might be care homes, respite, it could be if they attended day centres, schools, where all the different places they'd go to. And I basically could create this kind of holistic image of this person. It would be an assessment that takes into account lots of different things about that person. So there'd be the weight and height of that person, which is really crucial as a dietitian to know. BMI isn't something that I looked at. So BMI isn't appropriate for a large number of the general population, but when it comes to someone who has a learning disability, it's even less relevant. For those who don't know, BMI is kind of a figure which looks at weight against height and comes up with a number. And that number then puts someone in a category to say whether they're overweight, underweight, or like within a healthy weight range. But if somebody has perhaps low bone density because they are non-mobile and therefore a bones weigh something, so that calculation wouldn't work for them. Also, if someone's not using their muscles, it would come up with an accurate figure. So that's not something that I would do. Other things I do take into account: blood test results, what their medical diagnosis are, current physical health conditions. So almost doing a top to toe check. Is there anything going on with their teeth, their mouth? Is there any discomfort there? Reiterating what's going on with their swallowing that the speech and language therapist had spoken about, talking about kind of reflux and upper gastrointestinal tract issues, and then think about their stomach. Are they experience any bloating? Is there anything in that area of tenderness? And then think about their bowels. So how frequently do they open their bowels? Are they constipated? Do they have loose stools? Is there blood in their stools? And then talk about their urine output, asking if they've got any pressure sores. So really thinking about the body as a whole, then looking at what food and drink they're managing to consume at the time, but also taking into those environmental factors. So how does the setting that they're eating and drinking in meet their needs? Is the environment overstimulating to them? Are there lots and lots of people? Is it busy? And that doesn't work for that person. Are they kind of struggling to focus at a meal? And then I kind of take all that information and appraise it, analyze it. So look at their risk of malnutrition, calculate their nutritional requirements and compare that with what their intake is, and look to see, is there an excess? Is there a deficit of something? Most of the patients that I would see would have an issue with being unable to meet their full nutritional requirements. And so I'd have to take into account that person's physical health needs, but also their individual preferences when it comes to kind of making recommendations. I would typically recommend nutrient-dense foods and drinks for that person so that every mouthful counts in terms of calories, protein, micronutrients, which is your vitamins and minerals. Yes, there are prescribed nutritional drinks available out there. They weren't something I would routinely recommend. So just to name a couple of brands that people sometimes refer to them as, there's Ensure, Fortisip, Complan. I would steer clear of those routinely because it's possible to create homemade drinks that have a nutritionally similar profile but are much more palatable, more familiar to that person, can be better individualized to suit that person's preference, and cost the NHS a lot less than some of these drinks that can be between £3.75 up to sort of in excess of £8 per bottle.
Wow.
So if someone weren't able, there were occasions when someone did require those prescribed supplements if they had very specific needs. If they couldn't meet their nutritional needs after I'd put that advice in place, tube feeding might need to be considered. So in hospital, this is typically known as NG, or nasogastric feeding. And in the community, it's known as PEG, or PEG stands for percutaneous endoscopic gastrostomy tube feeding, but that's called home enteral feeding when someone's in the community. And so that might be the path that person then needs to kind of go down. Typically, someone who has a learning disability will have communication difficulties, and these need to be taken into account when thinking about what the nutritional plan is going to be for that individual.
Well, before I go on to my next question, I mean, one of the things that just struck me about all that is the number of question types a dietitian is going to use in gathering that information. I mean, even the basic questions about weight and height and all the rest of it, but going down to likes and preferences and why someone wouldn't like a particular food. So I should imagine for a dietitian, questioning techniques is like your bread and butter, so to speak. So getting on to the next question, which is about communication. So we often think about a dietitian's role as to provide information about dietary needs. So what communication skills do you use to make sure that once you've gathered all that information, that your message is understood?
Before I go on to that, I just want to kind of jump back to a point that you really nicely highlighted, is about gathering that information from people. One thing that springs to mind when you mention that is a challenge around making sure that information is accurate and the availability of that information. So if, for example, you mentioned weight, somebody might not be weight bearing and need specialist scales, and they might not be available so it might be wheelchair scales or hoist scales, and that can kind of create limitations for a dietitian in terms of what information they can gather. And so sometimes you're kind of bridging the gap by eyeballing somebody, by looking at them and thinking, how do their clavicles stick out? Are their shoulder bones prominent? And so that's kind of where I go back to that holistic way of looking at somebody. Also, it might not be a nice experience for somebody who has a learning disability, doesn't fully understand the situation, to be plonked on some scales, told to keep still. That might not be kind of appropriate for some people. Sorry, that's a bit of a tangent.
No, that's also really interesting, because sometimes we just think, right, we'll ask a question, but there's so much preparation that goes on around getting the environment right to be able to ask the question and get the correct information. So very interesting. Exactly. So now you've got your information. How do you make sure that it's understood?
So just like you said, the getting the environment right is really important. So can that person, and this is, I'm not just thinking when I talk about people who've got a learning disability, I'm talking about anybody that you communicate with as a dietitian or as a therapist, is can that person see and hear you? Are they likely to be distracted? Is it the right time of day for that person? So are they kind of feeling hungry, feeling tired? Are there other factors that might create barriers to that communication, so around how that person's feeling? Are they anxious? Are they in pain? How do they feel about meeting a new person? And they're all things to kind of they're things to bear in mind, especially when you're starting off that initial communication with somebody. Thinking just an appointment letter, what a difference it can make by having your photo and your name on an appointment letter, say that you're a familiar. That's to anybody. That's to a child, an adult, someone with a learning disability. It just breaks down that kind of a different barrier and anxiety that somebody could have. I think that building rapport through listening skills is really good and really key to communication. So to kind of tune in to how that person communicates with you and learn from their communication skills, and learn from how they communicate with you, to match that, to mirror it and communicate back to them in a way that it is the same as theirs. For example, if someone uses medical terminology or acronyms, so such as dysphagia, PEG, it's okay to repeat back to them those words. It's fair to jump to the conclusion they have that knowledge and are familiar with those. But I wouldn't use that medical terminology if that person hadn't used those words. Instead, I would try to use everyday language. I would remove the jargon. So instead of dysphagia, I'd say a swallowing difficulty, a difficulty swallowing. Instead of saying a PEG, I would say a feeding tube that goes directly into the stomach. And the other thing to think about is not all communication is verbal. In fact, the majority of communication isn't verbal. So looking at those kind of subtleties in somebody, are they nodding their head? Are they following you? Have they got a bit of a confused facial expression? Do they look disengaged? Is their eyes glazed over? And are they zoned out? And you can gauge from that person's probably not understanding, that you've possibly overwhelmed that person. It's also important to give people time to process what you're talking about, what you've said. So allow for pauses for them to think before you kind of jump in and say, do you want me to rephrase that for you? Because I'm talking from the perspective of being someone who is neurodiverse, and I'll come on to that a little bit later. But it takes me a little while, especially with questions, to think, oh, what does that really mean? How am I going to answer that? And then if someone jumps in there and repeats the question, slightly phrased differently, I then have to go back to the beginning and think, oh, hang on, is this the same question? Is it a different question? How am I going to answer it? So just slow it right down. Let somebody have the time to process the question, to process their answer before they kind of give a considered response. In addition to kind of processing the information, you need to think about how that person is going to retain it outside of that conversation. So what can you give them to support them and reinforce your message? And I tend to think a maximum of 3 to 5 key bullet points on a piece of paper, so it's not overwhelming somebody. And that's really key to implementing change, to kind of keep it simple and achievable. Hopefully people would have heard of SMART goals, kind of related to that, but a maximum of 3 to 5, and for somebody 1 is enough. It depends on the individual.
That's really interesting. And I mean, I know when I was teaching nurses that the rule of 3, my rule of 3, you know, when you're explaining something, I always used to say, keep it to 3 and signpost, you know, the first thing, the second, the third. So that's very interesting. So you've touched on communicating with a person with a learning disability. So what are some of the challenges of communicating with someone with a learning disability, and how have you overcome these, or what little tricks have you used?
So people who have got a learning disability can find communication challenging. And it's really important to learn from people who communicate with that individual on a daily basis, and make use of communication passports. It might mean that you're using closed questions, as that person can only reply by yes or no. Now, the way that they reply by that yes or no, it could be verbally, it could be a nod of the head or a shake. But for someone who perhaps has cerebral palsy and has limited body movement, it could be something that's very, very subtle that only their family and carers know about. And I worked with somebody, they glanced left for yes and right for no. So that was something that you then had to kind of you took the time to make sure those questions were going to give you as much information as possible, and that person would then feel included in the conversation. So asking closed questions, also communicating with people, again, thinking you're utilizing what their familiar people have informed you, and you are learning about their communication style. So it might be Makaton sign language. Something I need to be very mindful of is I do sign Makaton sign language. I can also use my hands a lot when I talk, as you can see. Now, for somebody who doesn't use Makaton sign language, that can be distracting because it takes the focus away from my voice, or it could be quite a bit of an insult if they see that the other people that they live with are communicated to by sign, and that's not how they communicate, and you're saying like, what do you eat? And they're thinking, I understood what you said, why are you signing at me? It's just being really mindful of that person's needs. So there's that side of things. There's also, you can communicate using objects of reference, which reinforce what you're saying. So it could be, only because I got it beside me, cup. You're saying like, which cup? And using what there is available to have that conversation around the item. It adds context for that person. It could be that you're using photos. It could be that you're using clip art images, or you're using symbols. It's great. You should consider how that person will interpret that image. So there's more clarity when you're using an actual physical 3D item in front of you. If I were to take a picture of this mug, you probably would know it's a mug still. If I were to do a clip art of the mug, then you might think, oh, is that saying cup of tea, cup of coffee? Like, what does that mean? If it was a symbol, that will be a further disconnect from the actual meaning of that word. So it's good to be mindful of it. Yes, there are PECs, which are different communication methods. It will vary as to whether that person uses it. You should never jump to an assumption or just produce some standardized kind of literature resources for that person, assuming that will meet their needs, because it might not. So I said about kind of the interpretation. I think checking in with someone's family and carers, or seeking advice from a speech and language therapist who, in addition to considering someone's swallowing ability, also have the role about supporting people around their communication. Sometimes practical demonstrations can be a good way to communicate with somebody, communicate like a message or teach something. And dietetic support workers, dietetic assisted practitioners are really vital with this aspect. Also might need to involve an occupational therapist to assess somebody's kind of kitchen skills, their safety, and put advice in place if there needs to be any adaptations around equipment for that person. I'd mentioned not everybody might be a verbal communicator, or verbal communication could be difficult for somebody at certain points. So they might be able to have a conversation with somebody one day, but how they're feeling might prevent that another day. I just want to touch on it, that this can kind of lead, it's important to be aware that some people can express their communication through challenging behaviour because they're struggling at that time. So it could be that a challenging behaviour that challenges, it's referred to in different ways, but they might change their behaviour as a way of communicating pain or discomfort. And this can sometimes create diagnostic overshadowing, where the behaviour is being treated. Someone's thinking there's a change in their mental health, where actually the underlying cause, the result, the pain, the constipation, the discomfort, that's actually what is causing the behaviour, which is a communication of pain. I think it's important to always consider to make sure that person is involved throughout the whole process. So I think that kind of brings me nicely onto the Mental Health Act, Mental Capacity Act, and thinking about that person's ability to make decisions for themselves. And that's something that's really important for a person who works in learning disabilities to have a very good knowledge and awareness of, because there's a difference between a person's ability to make a choice. So do they want cereal or do they want toast for breakfast? As to their capacity around that decision. So do they know that cereal soaked in milk isn't going to cause them any swallowing difficulties? Whereas if they had toast that was overcooked, they didn't have the ability to chew it, that could increase their risk of choking or could increase their risk of aspiration pneumonia if it wasn't adapted to the right texture for that person. So yes, someone might be able to have a choice. They might be able to say, I want A over B. Do they understand what that consequence is for that person? So you complete an assessment, and it could be over more than one session, to see if they, first of all, to educate that person, to support them to learn, and then see if they understand the information, see if they've retained the information, and if they can balance up the pros and cons related to that specific decision in question. I think that's really important to also go back to, because someone might say, oh, they don't have capacity, but capacity is unique to the question being asked. So that's no, someone doesn't just have a blanket non-capacity. It's in relation to the specific. If they did lack capacity, it requires a team of people to kind of advocate for them to come up with the best decision, best interest decision is what it's called. And those key people will be anybody in their lives. You might need to get an independent advocate involved, but it would include all of the medical professionals and social care professionals who are involved related to that decision. The quality of life for that person needs to be part of the thought process. And I think it's really important, just because of things that I've encountered during my time as a dietitian, to be aware that quality of life looks very different for someone who's got a learning disability. And assumptions shouldn't be made purely on the fact that they've got a learning disability. So I have spoken to consultants in the past, and sadly there is almost a blanket, well, no, we're not going to perform this medical procedure on this person because they've got a learning disability. How's it going to enhance their quality of life? The quality of life for that person could, back to like those things that I mentioned right at the start, it could be that they love listening to music. It could be like they like the feel of water. That's quality of life to that person. It's the engagement with their family. And yes, it's not the same as going to work. Yes, it's not the same as participating in sports and activities, but it is a quality of life to that person and shouldn't be dismissed. I think just to continue to keep in mind that food and drink are vital for life. And for some people who've got a learning disability, their health issues can impact on the choices that they're able to make. So one thing that I feel kind of privileged in a way as a dietitian to be able to do is to learn someone's preferences around food and drink, and where possible to continue to enable them to enjoy those tastes, those smells, those textures in a way that's safe for them to be able to continue having.
Yeah, that's really interesting. Before I go on to the next question, I've just popped in the chat box. There were a couple of terms that you mentioned that people may not be familiar with. So PECS, Makaton, and the communication passport. So I popped those in there if people might like to ask you about it or do their own research. So, so going on to something that you and I have discussed, that people with a learning disability are more likely to have poor health outcomes, and this is quite this is documented quite fully, isn't it? More likely to have poor health outcomes than the general population. So, what can you talk a bit more about these? What are they?
Yeah, so a learning disability is a significant lifelong condition. It starts before adulthood and it affects an individual's development and their ability to understand new or complex information, their ability to learn new skills, and their ability to cope independently. Now, to what extent that that has an impact on that person's life will vary, and external support factors have a large influence over that, both in childhood and adulthood. I wonder if at this point it's important for me to just mention the difference between a learning disability and a learning difficulty. So a learning disability, as I mentioned, is a lifelong condition. It starts before adulthood. Acquired brain injury would be something that happens in adulthood, so it's different, but it may look similar if you see somebody presented in front of you and is nonverbal. A learning difficulty, it isn't the same, that person can process information, they can learn new skills and cope independently, but the support they might need would be different compared to the general population, but the severity is a lot less. Yeah, so I guess alongside a learning disability, someone can also have physical health diagnosis such as Down syndrome, Prader-Willi syndrome, cerebral palsy. People with a learning disability experience significant health inequalities, as you mentioned, and barriers to accessing good healthcare. Data from 2019, so this is from LEADER, and I'm going to struggle to remember what it stands for, something to do with looking into the deaths of people who have a learning disability. Might want to Google that one, LEDER. But it shows on average that the life expectancy of women with a learning disability is 27 years shorter, and for men 23 years shorter than for the general population. And when you look more into the data, into the leading causes of death that have a kind of a link to diet, constipation is one of them. Osteoporosis is another. So to be able to have strength within the bones, someone needs to be weight bearing. If somebody mobilizes using a wheelchair, then they're not going to have that bone deposit and will have osteoporosis. Think about, I've already mentioned undernutrition, so I'm not going to kind of come on to that side of things. But in addition to that is the obesity rates and the increased risk of the comorbidities such as cancer, cardiovascular disease, hypertension, type 2 diabetes. When you kind of feed into the fact that that person might not be able to develop a knowledge of those different conditions, might not be able to have an awareness, also is reliant on other people to meet their health needs or their day-to-day needs, their control over and their ability to reduce those risks is limited. So I think one thing is to ensure that any kind of mainstream programs for support around, I'm thinking like cardiovascular disease, post-stroke education programs, type 2 diabetes education programs, or just a normal dietetic clinic when you're sitting in a one-to-one clinic room. It's important they're accessible to meet that person's needs, to help overcome those barriers to communication, and these are known as reasonable adjustments, and they can look very different to each person, so involving that person, involving their family and carers to find out what reasonable adjustments are required ahead of meeting them. So it could be ahead of a clinic, ahead of going to the ward, ahead of visiting in their own home, to find out this information about what reasonable adjustments are required. They can look very, as I said, look very different for each individual. For it might be that you extend your clinic, that you have a double slot for that person. It could be that you are prepared to create some resources that meet their communication needs. Yeah, I just kind of to add at this point that a dietitian's role is only part of the picture. So with someone who's got a learning disability, because there are all of these other health factors, a multidisciplinary approach is really important to managing their health, taking into account their physical and mental health needs. And over time, and just working really closely together, kind of collaborating, talking, coming up with plans together. It also, from a patient's perspective, not having to repeat information, not being bombarded by one person each day with appointments. If you can kind of work together, it's a much better approach. And over time, as working as a dietitian, I've worked with a number of different allied healthcare professions. So I've mentioned occupational therapists, I've mentioned speech and language therapists, but there are 14 different allied healthcare professions that are come under HCPC, so Healthcare Profession Council registration.
And also, I mean, added to that would be dentists and doctors.
Yes, yep. So they, and so it's not only the allied healthcare professionals that would be kind of brought into those conversations. So social workers.
Yes.
And I can see Roz has just popped in the chat, social workers.
Yes.
And the doctors, it could be a specialist doctor, so it could be kind of a gastro specialist, renal specialist, nurses, learning disability specialist nurses, but also considering their mental health, there might be psychiatrists, psychologists, they could be working with arts, music, drama therapists. So a huge range of different people who
and then looking at that from a communication perspective, you've got the you need the ability to not only communicate with your patient or client, you've got that colleague to colleague communication skill that is it's pretty high level and complex communication skills required.
And as I mentioned earlier about that kind of the conversation that I've had with the consultants in the past, where I was advocating for this person that they perceived to not have quality of life, it is a skill to be able to put yourself out there and be able to try and influence when you don't necessarily have that perceived authority.
Yes. Difficult. So the next, we're now moving on to your current role, which is slightly different, still within the AHP role. So can you tell us a bit more about your role as a practice support mentor lead, and what does that mean?
Yep. So my current role is in the kind of feeds into recruitment and retention of allied healthcare professions in the local area. So through different development opportunities within my career, I've gained different skills and experiences in coaching, mentoring, pastoral support of other members of staff. So people who kind of newly joined the team, supporting students. So and also been involved in quality improvement projects. So through experience and opportunities, I've gathered different skills to be able to lead to where I am now in my work. I'm also, as I mentioned, I'm dyslexic, I'm neurodiverse, and I have an awareness of the strengths and challenges this can bring. But I've also got lived experience that I can share with others. So I guess that the heart of my role is that people in those early career stages play a really vital role in shaping the future of the NHS workforce. And it's really important that student learners, newly employed allied health professionals feel supported, feel belonging, and able to develop their career pathways that are the right for them. So they feel that they're going to be retained, stay working within the NHS, and my focus is working within the local area, within the integrated care system, also known as an ICS, which the ICS oversees all of the different trusts and organisations within an area. So it includes all of the hospitals, all of the community trusts, the social care trusts, the higher education institutions that fall within that area, but also the private, voluntary, independent organisations. And ICS effectively looks, or ICB, so Integrated Care Board, used to be known as the CCG, just to confuse everybody. I'm trying to elaborate on the acronyms as I go. CCG, Clinical Commissioning Board. No, Clinical Commissioning. Help me, Virginia. What was it?
Forget it, because it's gone.
It's moved. So yes, we don't even need to know that. So the ICBs.
ISB and ICS, isn't it?
Yeah. So the IC group. Oh, thank you, person in the chat. So now we have the ICBs who look at the needs of the population and decide effectively where the money and effort needs to be injected into. So that's the ICB, and then the ICS is the system. What is
the overall arching
that area? Yeah. So I work at a systems level, making sure those allied health professionals who are a student through to that, those first 1 to 2 years in their job, have those positive experiences. And so they want to stay within that chosen profession, within that organisation. So some of the examples of support that I offer to people is, and just to kind of link into how Virginia and I got to know each other, is it includes those who are new to living and working in the UK. So my role as a legacy mentor is another way that my role can be put across. It's similar to a PNA or PMA, which, something nursing associate or midwifery associate, and the P is what I'm lacking. If anyone knows what the P is, please put it in the chat. But effectively, my role is to provide that safe place to talk, that door that's always open. I can signpost people to health and wellbeing resources, to disability, neurodiversity, reasonable adjustments advice, give them careers advice. So talk to people about applying for jobs, so job searching, how applying to jobs in the NHS is a little bit different from your covering statement and CV, and that's a technique that perhaps if someone's new to the UK isn't familiar with. And then helping people with their professional and personal development, so providing them with coaching and mentoring. My role collaborates with all the stakeholders within the system. So it includes the higher education institutions, placement providers, the coordinators, allied healthcare profession leads for all the different departments, to identify. So I kind of rely on them to identify who might benefit from my one-to-one input. So almost they refer to me. And I also have a part to play in projects, and that has a wider spread impact. So that's, again, back to how Virginia and I got communicating with each other, is that it was identified that there needed to be a greater provision for allied healthcare professionals living and working in the UK who've come from abroad around those communication skills. And that's one of the projects that I've been involved in. current project that's taking a lot of my focus is around the new allied healthcare profession preceptorship standards that were launched a couple of weeks ago by NHSE and HCPC to review what's so my part of the project is to review what's currently provided by the organisations within the local area, to see how to kind of support them to do that self-assessment, to see how they meet the standards that are required of them, and to look at where there are any gaps in their provision and then make recommendations around improvements. So for those who don't know, preceptorship is that first year, it can vary, the period can vary, but in a new position. So it could be that a newly qualified person goes through the preceptorship. It could be someone new to the UK goes through the preceptorship. It could be someone who's previously only worked in acute hospital settings and now is going over to a primary care organisation, goes through. It is helping them familiarise themselves and have that sense of kind of belonging, increasing their awareness in those settings. It bridges the gap between somebody being a competent person, so a competent person with the knowledge that they require. So I'm thinking a student, third-year student or final-year student who's just come out of study, they've got the tick boxes ticked, they passed, they know everything they need to know to be able to be a registered professional. They've become a registered professional. They don't have the hand holding they used to have, but they do have the same accountability. And they, particularly with allied healthcare professionals, have a lot more autonomy. And so the preceptorship bridges those gaps. It's a supportive measure that's put in place. It's not something that someone is assessed against. It's not, you have to complete it to get from band 5 to band 6. It's there are no tests, but there shouldn't be any tests. It is that organisation's provision to you, to your development as a person, to support your career moving forwards, but it does help you network. There's often kind of group WhatsApp chats, but
it could also be the difference between feeling comfortable in the UK or in your new environment, for someone who's not comfortable in a new environment if you've come from a different country, and deciding to stay, or feeling totally overwhelmed and just not being able to do your job. And it's also that valuable, the real workplace language that they probably haven't, doing a language test, for example, won't give you that specific workplace language. And, even you've mentioned jargon and things like that, so that it's feeling comfortable with all of that. So really valuable. And so finally, what do you see as the future role of the dietitian? What do you think some of the challenges dietitians will face in the future around nutrition and good health, for example? And what would be your wish list?
I think there's always going to be a need for dietitians. Nutrition is the foundation of life. Diet changes as well. So there's a greater consumption of processed foods at the moment, more need for convenience as life pressures change for people. But there's also new advances in medical research. People are living longer. It's kind of an ever adapting field, as with all of the as with kind of medicine, healthcare in general. It's really important that dietitians keep up to date with these changes, and that can help inform their evidence-based practice. So what was kind of the normal thing to say, the normal thing to advise when I learnt in university might not be the same. There's definitely been a lot of changes around the advice on thickeners for swallowing difficulties, and advice around the texture modification. And you can look on the Royal College of Speech Language Therapy to find out more about that, because it's not my specialism, so I don't want to kind of, I'd rather signpost you. But it impacts on a dietitian's role, and it is ever changing. And I think on a kind of personal note, on a wish list note, I've got 2 young children. So for there to be more investment around those kind of health promotion, early years education on getting nutrition right at that formative stage. It varies where money is injected into. There are some areas where it's identified that there are greater needs, and therefore local authorities will tend to invest in programs to support parents and children and improve their diets. But I just wonder if there needs to be a bit more of a blanket approach, more vegetables coming up on adverts. But yeah, that's kind of my wish list.
Yeah, interesting. Well, it looks really interesting, and I think, gosh, we could talk forever. So interesting, particularly the what you've spoken about with learning disability, because you don't often, well, I didn't really connect the role of a dietitian and learning disability as much. I can see now how important it is, and those communication challenges. It's really interesting on the different ways of overcoming those. So Bethan, over to questions.
Great, thank you so much, Emma and Virginia. That was really really wide-ranging and really interesting, and we've had like we say some interesting kind of comments and ideas in the chat. So we do now have some time for questions, so if anybody in the session has some questions, please pop them into the Q&A. I had a question. I feel like mine's a bit of a straightforward question, but you mentioned communication passports, which is not something that I've heard of before. I just wondered if you could tell us a little bit more about them.
So I can talk from the angle of what happens in Hertfordshire, because it's where I work. People have what's called a purple folder, and in that purple folder there's information about that person, their preferences, including how they communicate and how best to communicate with that person. It also lists their health conditions, medical conditions, and there are sheets in the back of it that when they're seen by a medical professional, they pop in a note to say a very brief summary as to why that person was seen. And it helps when that person's not able to explain, I saw the dentist this morning, they've told me I need to have my tooth out. You can look in that record to see that. So it works communication that way, but there's also how that person communicates is detailed more in there. I don't know what's available in other areas, but I do know that there is a lot of kind of encouragement around making sure there's a document. This purple folder someone would take into hospital with them. It basically follows them around.
Okay.
Yeah, I can just add, there's a really good YouTube clip on that, and it shows a good way to approach a person with a request to take a blood sample, for example, and there's a bad way, and part of it is the way that person likes to receive requests or information, and it might be a matter of explaining that in a minute I'm going to be doing this, not now but in a minute, and it really goes through how they like to receive information and requests. So yeah, very useful.
Great. All right, we've got a couple more questions. So if we come to our question from Ruz, Ruz's question is preparing overseas dietitians, which is one of the things that you mentioned that you as part of your very wide role by the sounds of it. What would be the most important aspect of communication to focus on, particularly with patients with learning difficulties?
Oh, that's a good one. because to place what's the most important aspect is quite hard. I would say that sometimes it's useful just gaining that fly on the wall experience for that person. So for them to spend half a day sitting in a day centre, a care home, where they can just observe how that communication happens around them and absorb from real life interactions, to be able to see what's used and then be inquisitive or encourage that overseas dietitian to be inquisitive and ask. It could perhaps look in a way of a reflection to kind of say, or if you were to go out and spend half a day in this setting and you have a series of questions to say, what did you notice about how other people communicated to that individual? How did that individual communicate to other people? And the subtleties around kind of changes in behaviour being a way of communication would get picked up at that opportunity. Hopefully that answers that question.
Yeah, we have from Ros noticing tasks, very nice, in the chat as well. Great. And I think we have time for maybe one more question. So there's a question going back to your point about allowing for pauses. So the question here is, how do you maintain patient independence? And the example is, for example, managing interruptions from family members or family members who perhaps take over the interaction or try to re-explain or try to receive information in place of the patient. So coming back to the question, how do you maintain the patient independence in that context?
Practice. and practice and confidence. I'm not going to say that comes immediately. It's through experience. I would say that you are there for that patient, that individual, and they need to be your priority. And with that kind of mindset, you're then thinking, yes, this is useful information to me, or it's not. And by doing that, you're then able to say, thank you for that. What I need is to hear from this person. And it could be that you have a conversation separate from the family members. It could be you'll say, or you have that initial conversation away from other people. So the benchmark is that the focus is on that individual, but it's fair to be firm, because you're, at the end of the day, you are there to support the person who's got a learning disability, and therefore to be able to cut somebody off, to say, okay, we're gonna, I need to talk to such and such now. But like
it goes
I said,
back to patient rights, doesn't it? Everybody has a right to be.
Definitely. And there have been occasions where I've said, thank you for your contribution. I need to have a one-to-one conversation with this person. I'm going to feed back to you afterwards. I'll let you know how it goes, because you don't want to get on the wrong side of somebody. But it just to, hopefully they would see it from the perspective of you're helping that person in the best possible way.
Great. Okay. So thank you very much for a couple of comments in the chat. So Ros has found us a link to the communication passport, more information that you're both talking about. And our comment for Joe is absolutely kind of managing people, and tactful language is a skill that we need to develop in general, probably.
Definitely. And I don't think it's something that can be taught, or you can you can teach on resilience, you can teach on influencing without authority, but until you are using those skills, it's practice. You need to be trying it out, and it will come.
Yeah.
Great. All right. Thank you so much for your talk today. It's been really insightful and really valuable for our members. So as you know, we're mostly educationalists and researchers. So hearing from healthcare professionals is such a valuable part of our professional development as medical English language teachers. And we've got lots of lovely comments coming in the chat here. Thank you. Really informative and great. All right, so thank you both so much for your time and contributing. And we will be sharing our recording, as I mentioned, via email, and then it will be on the Ealthy website. Please look out in your email inboxes for information about the next Ealthy webinar, which should be coming to you in the next few days. All right.
Thank you very much, Emma. It was great.
Oh, it was a pleasure. Thank you so much.
Thank you.
Thanks. Bye-bye, everyone.
Bye.
Bye.